Yes, we've come to the third to the last topic of our concept, health assessment, and we're going to tackle the female reproductive system. The female reproductive system includes the ovaries, oviducts, vagina, and the external genitalia, located in the pelvic region, along with a pair of mammary glands. Of ovulation, fertilization, pregnancy, childbirth, and childcare. So let us study each organ in detail. The female reproductive system includes the pair of ovaries, located one on each side of the lower abdomen. The primary sex organs as they produce the ovum of the female gamete. Each ovary is about 2 to 4 centimeters in length. They are connected to the pelvic wall, and the uterus is by ligaments called mesothelium. Each ovary is covered by outer thin layer called the germinal epithelium. The germinal epithelium encloses the ovarian stroma, which is further divided into the outer cortex and the inner medulla. Cortex consists of many ovarian follicles in different stages of development. The ovarian follicle is the basic unit of the female reproductive system. It is composed of roughly spherical aggregations of cells found in the ovary. The accessory ducts of the female reproductive system are the vagina, oviducts, and the uterus. The pair of oviducts or fallopian tubes is about 10 to 11 centimeters long and extends from the periphery of each ovary to the uterus. Each of the duct is differentiated into 3 parts, namely, the infundibulum is the latent funnel, close to the ovary edges. Edges are surrounded by finger-like projections called the fimbriae. They help collect and push the ovum into the oviduct after ovulation. The ampulla is the swollen and curved part behind the infundibulum. The fertilization of the ovum takes place in this part. The narrow and straight cavity, and it joins the uterus. The uterus is a hollow pear-shaped muscular organ and is highly dispensable. It is situated in the pelvic cavity between the urinary bladder and the rectum. It is also known as the womb. It is supported by ligaments attached to the pelvic wall, known as mesometrium. The uterus opens to the vagina through a narrow cervix. The cavity of the cervix is called the central canal, which, along with the vagina, warms the birth canal. The wall of the uterus is composed of 3 layers of tissues. The outer thin membranous layer is called the perimetrium. The middle thick layer of smooth muscle is called myometrium, and it helps during delivery by producing strong contraction motions. The inner glandular layer is called the endometrium, and it undergoes cyclicals during the menstrual cycle. The vagina is a muscular tube starting from the lower end of the uterus up to the outside. The opening of the vagina in young female is partially covered by a thin membrane called the hymen. The hymen is frequently ruptured in childhood due to strenuous physical exercise. The female external genitalia includes the mons pubis, labia majora, and labia minora, and the clitoris. The labia majora consists of freshly folds of tissue that extends down from the mons pubis and surrounds the vaginal opening. Hidden under the labia majora is the labia minora. Firend lies the clitoris, a small finger-like structure, and below it is the urethral opening. The female reproductive system is supported by the mammary glands. Breasts are modified sweat glands that live over the pectoral muscles. They contain glandular tissues and a variable amount of fat. Internally, the breast is divided into 15 to 20 mammary lobes containing clusters of cells called the alveoli. The alveoli open into mammary tubules, each lobe joined to form the mammary duct. Several ducts join to form a wider ampulla. It is connected to the lactiferous duct. The lactiferous duct opens out through the nipple, from which milk is sucked out. We will also include the rectum, the anal canal, and the anus. So the rectum is approximately 12 cm long, about 4 3/4 inches, and is located above the anus. The proximal end of the rectum is continuous with a sigmoid colon. The distal end, commonly referred to as the anorectal junction. It is identifiable during a colonoscopy as having a sawtooth-like edge. Located above the anorectal junction, the rectum dilates and turns posteriorly into the hollow area of the coccyx and sacrum. This forms the rectal ampulla, which stores flatus and feces. 3 semilunar transverse folds, known as rectal valves, are located in the rectum. The valves extend across half the diameter of the rectum, with the inferior valve palpable on digital examination. The exact function of these valves remain unknown. However, the valves may impede defecation while flatus is being expelled. The female's anal canal is approximately 2.5 to 4 cm, about 1 to 1.5 inches long, and extends from the anorectal junction to the anus. It is lined with mucous membrane arranged in longitudinal folds called rectal columns, which contain a complex system of veins and arteries, commonly referred to as the internal hemorrhoidal plexus. Between each column is a recessed area called the anal crypt. The perineal glands empty into the anal crypt. Around the anal canal are 2 concentric rings of muscles, the internal and external sphincters. The internal sphincter contains smooth muscle and is under involuntary control. The sensation to defecate comes from the rectum filled with stool, which causes reflexive stimulation that relaxes the internal sphincter. The striated external sphincter consists of skeletal muscles and is under voluntary control of defecation. The anal canal perceives pain differently. The autonomic nervous system controls the upper portion, which is relatively insensitive to stimuli. Conversely, the lower portion, which is controlled by somatic sensory nerves, is sensitive to stimulation. The anus is the terminal portion of the rectum. Its moist mucosal tissue is pink and surrounded by hyperpigmented perianal skin. Hair may be present in the perianal area in an adult. Normally, the anus is closed except during defecation. So for the lifespan considerations, the cervix of a pregnant woman has visual and tactile changes as compared to that of the non-pregnant women. Generally, the cervix takes on a bluish hue as well as becoming higher and softer after conception. On assessment of the newborn girl, it is not uncommon to see some pink discharges at the opening of the vagina. This is most often as a result of maternal estrogen and resolves within 1 to 2 weeks after birth and cessation of exposure to maternal estrogen. The external genitalia of the newborn girl may also be somewhat engorged because of exposure to maternal estrogen. The labia majora, flattened, and labia minora are flat and thin as girls mature past infancy. Assessment of the external genitalia only for girls is routine. If urogenital tract difficulties arise, then a more detailed assessment is necessary. When assessment is done, it is important to explain to child that this area of the body is private and only her parents or the healthcare provider can ask to look at the area. Internal genital assessment of the adolescent is not required unless genital tract difficulties arise. So pap smear is to be started at age 21, regardless of sexual activity status. However, adolescent is a good time for patient education about sexuality and relationships. The adolescent is experiencing body changes, self-identity, exploration, and relationship questions. You should be direct and honest with the teen. Establishment of a trusting and confidential nurse-patient relationship is vital. Sexually active adolescent females should have an annual examination and annual screening for sexually transmitted infections. Women older than 65 years represent more than 15% of the population. As women age, they experience many changes in the genitourinary tract. Most of these are related to limited or absent estrogen in the system. Menopause is defined as 12 consecutive months without menses, as estrogen levels decrease. The uterus becomes smaller, the ovaries shrink, the normal vaginal urethra flatten, and the epithelium atrophies. These normal changes may lead to difficulties such as vaginal infection, urinary tract infection, dyspareunia, and diminished libido. Older women are at increased risk for endometrial, vaginal, and vulvar cancers. They need education regarding unexpected signs and symptoms. The older woman also may benefit from counseling and education about intimacy difficulties and physiological changes. For cultural considerations, age of onset of puberty in US, girls has declined over the past century. However, the steepness of the decline has leveled off somewhat in the past few decades and is not much different now than age of onset reported in 1973. According to the American Congress of Obstetricians and Gynecologists Committee on Adolescent Health Care, the U.S. median age of at menarche is 12.4 years. African American girls may begin puberty before 8 years of age. Onset of menses correlates with estrogen release by the hypothalamic pituitary ovarian axis. Budding at the breast occurs first, followed by development of pubic hair. Onset of menses follows breast budding by approximately 2 to 3 years. The Tanner stages of maturation are used to assess pre-adolescent and adolescent females. So here is the Tanner staging, female pubic hair. If the patient is experiencing severe pain or excessive vaginal bleeding, the assessment needs to be truncated to involve only questions pertinent to the immediate condition and necessary for current care. It is important to perform a thorough symptom analysis to evaluate these problems. An ovarian cyst may be present at the reason for pelvic pain. Pelvic pain needs to be assessed quickly because some causes are life-threatening. An ectopic pregnancy is an example of an urgent situation and a potentially life-threatening cause of pelvic pain. Suspect this condition if a normally menstruating female is experiencing pelvic pain and is a week or two late for her menses or has experienced a menstrual flow different than normal. So for our subjective data collection, the assessment of the female genital system is very invasive and can be uncomfortable for both the patient and the nurse. During the initiation of health history, allow the patient to become comfortable with you. As you acquire important data about the patient, you will feel more confident. It is important to project a respectful, judgmental demeanor. The room should be private and comfortable. You should be seated at the eye level or lower than the patient. Reassure the patient that all information is kept confidential. It is best to obtain the history while the patient is dressed. This reduces potential patient embarrassment and vulnerability. If this is not possible, make sure the patient is completely covered, warm, and comfortable. Make eye contact, but be careful of nonverbal communication. Often, minor cues give the greatest amount of information. Begin the interview with less personal basic biographical data when requiring about sensitive topics. It helps to normalize the experience by starting the question with a phrase such as, "Many patients have questions about sexuality." Talking about sex with patients have a direct impact on unintended pregnancies and STIs, or sexually transmitted infection. In cultures that have greater sexual influence and candidness about sexuality, there are less problems with sexual experiences, increased contraceptive use, fewer STIs, and fewer unintended pregnancies. Women want practitioners who know the way they feel about sex matters. Many women, however, are too embarrassed to bring up the topic, although most will discuss sexual concerns if their provider introduces the topic. The sexual history includes gathering data on the 5 P's. What are these P's? Partners, pregnancy, prevention, protection against STIs, sexual practices, and past history of STIs. Avoid making assumptions when talking with patients about sexual matters. Some common misconceptions are the following. Sexually experienced people know how to use safer sex techniques. People with good jobs and families do not experiment sexually. Single people have lots of partners and riskier sex practices. Older people have fewer partners and infrequent sex. Married people are heterosexual and do not have sex with partners at the same gender. With practice, you will become more fluent and comfortable talking about the female reproductive system, STIs, contraceptions, and sexuality.